Thanks so much, CJ, and it's a joy to be with you all and to welcome you to our second Theology, Medicine, Culture Seminar of the year. As CJ said, we really would invite you all to consider partnering with us further with some of our programs. Please don't hesitate to reach out to me or to any of my colleagues if you have questions about that. And also, as CJ said, we'll have time for questions at the end. You can give those in the chat to me, but I hope that some of you will risk raising your hand and turning on your video and audio to ask that question, but I'll facilitate that at the end. It's a real joy and a privilege right now to introduce our former TMC fellow and my friend, Jason Ashe, whose presentation today is entitled Racism, Driver of Health Disparities, Outlier in Our Theology of Illness. Jason was part of our first ever cohort of TMC fellows, and it's hard to believe that this May will be, I think, 7 years since that first cohort graduated. He's currently a PhD candidate at the University of Maryland, Baltimore County, UMBC, in the Department of Human Services Psychology, and his research explores how social determinants of health influence heart disease risk among Black Americans. Now, I have to be honest, a brief introduction just does not do Jason justice. He's a lover of art, he's an amazing vocalist, and he just can't help but talk too fast because he's from New York. It's a real joy to welcome my friend Jason to speak with us today. Jason.
Thank you so much. Thank you. Welcome, everyone. It is an absolute delight to be here with you all. I truly love TMC. It holds a special place in my heart, and so I'm delighted to be here with everyone today to talk about what I think is a very salient topic for what we're going through in our world. So the title of my topical presentation is Racism, Driver of Health Disparities, Outlier in Our Theology of Illness. Before I begin, I want to give 3 quick notes. Number 1, I am a psychologist now, so I've unfortunately drank the Kool-Aid and I've left theology for a little bit, so it might be a little bold of me to be trying to challenge theology in a space full of more theologians who have better theological training perhaps than I do, and so give grace as the Lord has asked us all to give. Secondly, I also want to bring up that this is a tough topic. I talk about racism a lot in my research and in spaces where I am just normally, but I recognize that in other contexts, sometimes the topic can be a little jarring and triggering. And so I invite you to take whatever breath and time that you need as I will be sharing what will be some difficult topics. There will be some media that will be here that could also be triggering. And so if you're having physiological reactions or psychological reactions, I invite you to take deep breaths and to calm yourself in any way that is necessary for you. Lastly, before I begin, I want to point you to the picture that is on the screen. So as Brett has just mentioned, I am an artist. I do love art. And so this is a piece that I started right when COVID-19 hit. So when we were sent home from classes in March of 2020, I said, well, great, now I don't have to do homework, so I can do some drawing. And so I was really excited to get back into art. And then, as you can imagine, in May of 2020, when George Floyd was murdered, and that really struck the nation in a different way. It was also very hard to witness vicarious racism, that which is not happening to me, but happening to someone who looks like me. And in that way, it was really hard to finish this piece. And this piece took on a completely different meaning. And so I have titled this piece, Don't Let Them See Your Eyes. As I'll be talking about art throughout our time together, I hope that you will also keep in mind that art is a cultural statement and it can tell us about what is happening in our world today. So as I will begin our presentation, I want to provide us all with some learning objectives. And so some of these terms may be very familiar to you. And for others, perhaps these might be the first time you might be hearing them or unsure of what they mean. And so I want to provide just some quick learning objectives so that we're all on the same page. And so I'm going to acknowledge racism as a social determinant of health inequity. And I'm going to describe how racism is institutionalized, structural, and historical. I'm going to then ask us all to consider if theology of illness addresses racism adequately, and then if so, or if not, in what ways can we make sure that in our future interactions and work, either as clinicians and healthcare providers, or for those of us who are in research, for those of us who work in churches, or in any space that you may be working with other human beings, how is this important for us to be thinking about in our future work? So, social determinants of health. Many of us know that in the westernized biomedical framework, we really think that our body and our health is really like 100% defined by our genes, our susceptibility to pathogens, any type of pathophysiological disturbances. But in actuality, there have been folks who've been saying that health really only comprises, that our biology and our genes really comprise about 20 to 30% of what makes up our overall health and our disease susceptibility, but rather that there are non-medical factors that affect a wide range of health outcomes, our daily functioning and our quality of life, and our risk for diseases. And we call those social determinants of health. The WHO, the World Health Organization, says that where we live, where we eat, where we go to school, where we worship, these are all different aspects of social determinants of health. And there are these 5 large domains that we define social determinants of health, whereby we say social support and community, so who we're seeing consistently, like our faith-based communities, the economic stability and our educational attainment, where we live, that environmental setting, and even our access to healthcare and the quality of healthcare that we receive. It is therefore no surprise that racism and discrimination, any unfair treatment that we might be victim to, also contribute to poorer health. In recent years, you've probably seen a lot of organizations and researchers calling racism a social determinant of health, but this is not a new phenomenon. In actuality, folks have been saying this for decades, that unfair treatment disturbs is a stressful situation, and it disturbs our body, and we are susceptible to diseases because of that chronic stress that we receive. Now, discrimination being unfair treatment, in the context of racism, though, we know that for racial minorities, and particularly those who have been historically marginalized in the United States, they experience discrimination at higher rates. And so a lot of work has been focusing on African Americans and Black Americans in the US, in part because of the socio-historical narrative of slavery, Jim Crow segregation, and as you can see on the screen, only the last few decades where we've been quote unquote free-ish. So across several national large studies and reports, we see that compared to other racial minority groups and other historically marginalized groups, Black Americans and African Americans tend to say that they are facing discrimination, or at least recognize that because of their skin color, they are experiencing discrimination. That is not to say that other groups are not experiencing discrimination as well. It is just so that we recognize that Black Americans tend to say that they are experiencing discrimination more. And they are experiencing this discrimination across a host of settings. So no matter where they are, they feel as if they are either susceptible to discrimination or they are actually feeling discrimination. So when they're at the workforce, they might feel that they're being looked over for a promotion, or even when they're applying to jobs, there's a lot of research that says that people with specific names, racialized, the way that we understand race and racialized names, are even discriminated against for certain opportunities. We also know that interaction with the police, again, we're seeing this consistently now in our media, but this is not a new thing, that African Americans and Black Americans are having very hostile interactions with the police. And so there are a lot of different ways that we are experiencing racism and discrimination, either interpersonally, or again, as I mentioned at the onset of our talk, vicariously, where we're seeing other folks who are being discriminated against. And because we share very similar identities, we also feel that trauma connected. And so as a health psychologist, we study the effects of racism and chronic stress on the body. And so there are a lot of studies, many of which you might already be familiar with, as Dr. David Williams gave his talk just a couple of weeks ago, where he was also detailing the effects of racism on the body. And so you will see that there are mental health outcomes that are adverse by experiencing racism or racial discrimination. So more depressive symptoms, hypervigilance, being overly aware that you might be susceptible to another attack or an insult or microaggression. Sometimes when you experience discrimination, you might even turn to certain coping strategies that are also not good for you. So perhaps using substances like drinking alcohol or smoking cigarettes. You might even have lower self-esteem. There's some research that's even coming out now that suggests that experiencing more discrimination has effects at the cellular level, where even those who experience more discrimination have shorter telomeres than those who are saying that they experience less discrimination. And we also know that discrimination and racism lead to a higher incidence and prevalence of cardiovascular diseases, other aging-related diseases, and even all-cause mortality. And so a lot of work that I've been working in studies the interpersonal interactions, how we might experience one-on-one daily interactions with racial discrimination. But there are other, like I said, organizations that are calling to our greater understanding that structural racism, that which is embedded in our institutions, in our systems, in our policies, in our history, that is also a significant driver of health disparities, where we are seeing these very stark differences across racial groups when we often compare those to those who are privileged, namely white folks in particular, and those who have higher socioeconomic status. And we're understanding that across different systems, different institutions that exist in this nation particularly, we see that racism is embedded and is pervasive, and it permeates a lot of these systems. And so it is the way that we have limited access to quality food, the way that we have income inequalities that show up, that Black folks will make less to the dollar than white folks might. Community and social context, where we're living, yet again, all of these are connected to the effects of racism as well, and all of these have adverse effects on our health overall. Now, I want to pause here and say that as folks who are probably working in the healthcare system, it can be perhaps a hope that we who work in healthcare and are delivering good quality health to everyone, we are hoping that we also are not adhering to any of these racist ideologies and tendencies. But I want to bring attention to some papers and some articles, some news articles that have been published within the last 5 to 10 years. And I'll just read a couple of headlines for you to also show that, unfortunately, our US healthcare system is also not devoid of racism. You'll see on the screen, if you were able to view it, titles that say the University of Virginia report shows that medical students believe Black people feel less pain than whites. False beliefs of medical students may lead to racial bias in pain management. Black children are more likely to die after surgery than white peers, coming from a study published in the Journal of Pediatrics. What Serena Williams' scary childbirth story says about medical treatment of Black women, showing that no matter how famous you are, you still are susceptible to racism in the healthcare space. And so again, these are stories that are coming out in the last 5 to 10 years. And so this is showing us that we are still dealing with racism. And there are a lot of ways that sometimes we're thinking that racism is this outside evil that we've had to deal with. Racism is this outside thing that is causing stress and strife for those who are witnessing it. And so it is hurting us internally, but it's not even in the systems where we're seeking healthcare. But that is not true at all. It is in fact embedded even in our healthcare system, where we as Black folks are going to see doctors and physicians and healthcare providers, and we're still getting treated as second-class citizens. But I also don't want to pretend that this is just kind of happening and it came out of nowhere, right? This is not just happening out of some we don't live in some vacuum and it's like poof, here came racism. But I want to point us to the fact that racism is historical. And so let us take a journey back to the 1950s. I am a teacher and I love to teach. And so allow me just a couple of moments to walk us through a historical time point that I think can show us even some other examples of how racism has been showing up in our healthcare system. So if you will remember, in the 1950s, that is right around the end of World War II. And so that is what's happening at a global standpoint. And so many of us are remembering that we are recovering from warfare, yet still as Black folks, we're also still feeling the effects of racism. This is a time period of the desegregation of schools, which also meant that Black children who are now going into integrated schools were faced with hatred from white mothers and white fathers who were outside of those schools trying to harm children going to learn. This is also the time when Emmett Till, unfortunately, was lynched by angry white men. And so this is all the racism that's happening around us, but what about that? What is also happening in the healthcare system? In the year of 1950, April 1st, Dr. Charles Richard Drew, a prominent African-American physician, he is known for developing blood banks where we can store and even do transfusion for those who might need blood. This is obviously very important right after World War II. And he is coming home from a conference with a couple of his colleagues, and he falls asleep at the wheel. And unfortunately, he suffers major injuries from a car accident in Alamance County. He is rushed to the hospital, and unfortunately, doctors cannot save him. There was a large myth that was going around that said that Dr. Charles Richard Drew was not treated equally because of his skin color and because he was Black. Many might actually argue that this is not true because other physicians would have known of Dr. Charles Richard Drew and would not have discriminated against him in that way. Now, I can't speak to what was happening in 1950 in that operating room and in the urgent care, but what I do know is that December 1st, 1950, at the illustrious Duke Hospital, Maltheus Avery, a 24-year-old veteran and a student at North Carolina A&T, was rushed to Duke Hospital because he had also just been in a severe motor vehicle accident. And when he got to Duke Hospital, he was turned away because there were not enough Black beds in the hospital available. Now, what is very clear is that because he is Black, the policy of the hospital where many of us have walked through those halls, said because of your skin color, there are no more available beds. It is not that we can't help you because of the lack of training. It's not that we can't help you because you're a fellow human being who is in need of help and service. It is the fact that because of your skin color, you cannot be here at this time because there are no more available beds for you. He is rushed to a nearby Negro hospital, which has since been shut down. But on the way to that hospital, he suffers from his injuries and succumbs to those injuries and dies. As you can see from the screen, there is a headline here that says, "Hospital refuses dying A&T student, lack of bed space given as a reason." I also want to just throw out a very interesting point that it also reads, "Trigger happy cops reinstated," a tagline that could also be read even in the year of our Lord, 2020. Fast forward just a couple of months up to the wonderful city of Baltimore, where I now reside. We see another story yet again of racism happening in our healthcare system. In October 4th of 1951, Henrietta Lacks is seen at Johns Hopkins Hospital. She is suffering from ovarian cancer, and unfortunately, she also succumbs to her disease. However, while she is there, doctors at the hospital biopsy her cells without her consent and describe her cells as dividing with robust energy. Sociological implications for that of how we even talk about Black women, both in medicine, but also in other spaces. I can't go into that today. Hopefully that is something that you can read upon on your own time, but also thinking about the way that we have stolen from Black women in medical systems and then profited from their bodies without to this day giving any type of reparation or any type of financial restitution to her family and lineage. We have profited from her cells in terms of the development of the polio vaccine. We've developed HIV and AIDS research based off of the HeLa cells, other cancer research, and even COVID-19 vaccines have been tested on the HeLa cells. It goes to show that she lives on, so to speak, but again, this was medical manipulation, exploitation, and to this day, her family still has not received any type of compensation except for perhaps an open apology. Now, I introduced those two stories and I stay at the 1950s because I always find it interesting that many of us in the medical community and those who study ethics or any type of bioethics are very quick to point to Tuskegee's study of untreated syphilis in the Negro male and saying that this was a study that happened for 40 years where 399 rural Southern men were not treated for syphilis. And in fact, were just told they had bad blood, were quote unquote given free healthcare, but all they were really doing was coming to get these services where they were watching them die. Imagine that as a physician and a healthcare provider, knowing that you have taken oaths to protect and help those who are in need, and you are just watching people die, watching them die to understand how physiologically syphilis can affect the body. This is the story that many of us tell as the reason why Black folks do not trust the healthcare system. But as I've already demonstrated for you, other things were happening in the halfway point of this story. 20 years before the 1950s, Tuskegee was happening. 20 years after the stories that I've just told you, Tuskegee was still happening, and people were calling out what was happening, but it took way too long for this to end. So again, let's fast forward back to where we are, present day, and it is 2020, and COVID-19 hits the United States, and we see very stark racial disparities whereby Black folks were more susceptible to severer complications from COVID-19, also by way of some of these racial health disparities in terms of risk factors like diabetes, hypertension, and obesity. Again, which we also should be now seeing in context of social determinants of health, whereby is racism and the neighborhoods where we live and other limited accessibility to better healthcare and food. There are different ways that this has been affecting us, but again, we are here now in 2020, and we're seeing these vast differences across who is dying from COVID-19. And then follow it up with an even more complex story that when we finally have vaccine rollout, vaccine uptake is less in a community that distrusts the medical community. In so many ways, as somebody who is Black and somebody who cares deeply about the people of God and also about health as an entity that we all should just have, health equity being something at the forefront of most of my research and my vision for a better tomorrow, I was stuck with this very hard and troubling question, and I kept praying a very dark prayer. God, where are you? God, do you not care about Black people? Do you not care that we continue to suffer? Do you not care that despite the fact that we are doing all that we can, we are still suffering because racism is still here and is still pervasive? I want to put a pause on that because what was also troubling but interesting to me was that because the Black church is a social institution that is very trusted among Black Americans, it was very quick, even from the mouth of Dr. Anthony Fauci and other public health officials and researchers and advocates, that we as healthcare providers and practitioners need to be partnering with the Black church to make sure that we are getting the vaccine out to those who are in need. And I applaud this effort so much. I appreciate this effort. If it wasn't for that quick thinking of let's get into the space where we go to the most, then of course we can reach more people and we can partner with pastors and help them to help us get the vaccine out. But it should also be alarming that we as Black folks would rather go to the Black church to understand the intricacies of health, where the MDiv is not an MD. I can be very honest and say that while I was at Duke and I got my MDiv, I just happened to take physiology because I thought that I wanted to talk about the physiology of the crucifixion. And Warren Kinghorn said, that's great, but that's not going to change lives. And so I appreciate Dr. Kinghorn for that. But most of us who are in seminary training don't really receive adequate intersections of health and medicine and theology. Rather, we might talk about how we can provide pastoral care and training and therapy for those who might need it. But what are the ways, though, that we as Black folks are going to our Black churches to better understand and partner with a system that is designed to actually provide health for, healing and treatment for us? It is interesting to me and has raised an interesting conundrum, which I then drew out on paper. And so this is obviously not a adequate research study. This is not a chi-square test. I haven't proven this, but I've seen a lot of research that would back me up to say that when it comes to trusting the healthcare system, we as Black folks are much more skeptical. Medical mistrust is high among the Black community. But when we come to the Black church, despite the flaws and all, despite the fact that we still have to deal with patriarchy and heterosexism and even ableism at times, if I can be honest, we still would rather come to this place and trust them more because we have an intimate connection, not just with God, but with the people around us who understand that the racialized world outside of us is affecting us so deeply. And it is here that we feel safe and we can come and pray our prayers with diligence and waiting for God to do something that we're asking God to do. And again, less trusting in doctors and physicians, but more trusting in this one that we call Jehovah Rapha, the great physician. And so it has made me think and has also made me wonder that we as Black folks have to trust in God to heal us, despite the fact that we are also dealing with a system, a medical system that is so anti-Black, that it is almost more possible that when we go into these settings for some type of surgery, that we will be treated differently, or we might not even come out. And so we have to pray differently because of the world that we are living in. Now, as someone who has also been a product of the Black church, I've grown up in the Black church. I've visited numerous churches over my life, those that are predominantly Black, those that are also multiracial, those that are also very predominantly white. And so I can say to you with a little bit of confidence that across the perhaps 100 plus churches that I have visited over my 33 years of living, Black folks, when we pray to God for healing, we pray differently. Now, for those of us who grew up in churches of hymnody, we might know the Negro spiritual that mimics the lines from Jeremiah that sound a little bit like this. There is a balm in Gilead to make the wounded whole. There is a balm in Gilead to heal the sin-sick soul. The way that we sing songs invites the Lord to heal us, despite the world that might be around us. There are ways that we are praying and the ways that we proclaim the goodness of God when God heals us by saying, He's the doctor that never lost a patient. You might hear sermonic cadences in Black churches that will sound something like this. He's a doctor in the sick room and a lawyer in the courtroom. If you are someone who has ever listened to John P. Kee is a pastor and gospel singer out of Durham, North Carolina. On his album, Wash Me, which came out in 1994, at the end of his song, Standing in the Need of Prayer, John P. Kee can be heard saying to those who are listening to him sing, he is giving a testimony about a child who is sick and he is going to the hospital, and the family is there crying, and the doctors say the results are confusing and all we can do is wait. John P. Kee says he gathers the family to pray, and he says when the doctor says no, Jesus can still say yes. There is something peculiar and idiosyncratic about how we as Black folks invite God into the healing space. And so with conviction, I come back to this question that I asked at the beginning of COVID-19 when I said, God, do you not care that we continue to suffer? God, do you not care that we continue to die disproportionately just because we're Black? And I felt the very harsh conviction of course God cares. Of course God is not pleased. Of course God continues to heal Black folks. I know it because I've seen God do it. I know it because I've seen and heard stories of God do it. But the problem is that theologically, we have these linkages of how we think that healing comes about by how we pray to God and by how God will gift us healing. And these prayers and these theological perspectives seldom take into account that there are social and structural determinants of health inequity, that racism and other forms of isms and phobias exist in this world. And if we as Christians and we as those who believe that God is a healer do not take into account how important it is that God is a healer despite some of these things, but also recognizing how powerful and how evil and how pervasive these things are, then we are presenting God, this great physician, as someone who is biased, because Black folks indeed live sicker and die earlier compared to their counterparts. And we cannot continue to pretend as if the great physician is working and at work in our hospitals and in our medical systems, and also not having to do work against racism as well. We have to account for that in some way in our theological questioning. One of the ways that I have started to think about this a little bit more deeply is a book that was assigned to us when I was, again, an MDiv student in class with Dr. Warren Kinghorn. We were assigned Theology of Illness, and I've loved this book. I've read it probably 4 or 5 times with different colors and highlights, and I've come to this landing point that Jean-Claude Larcher, French philosopher, he presents us with the different arguments that have come across Christendom, basically. And he also is formulating some very good and heavy lifting here. And he gives us these 3 main questions for our theology of illness. How did disease come about? What is God's role in either permitting or authoring disease? And how does the suffering person grow closer to God when they are afflicted? And I don't want to minimize his arguments too much, but in a nutshell, for the sake of time, I want to argue and present that Larcher tells us that disease has come about in our humanity's sake because of the fall of humanity, right? Where Adam and Eve ate of the fruit, and because of that, sin entered into the world. Because sin, the wages of sin are death, and therefore sickness and illness often lead to death. It is now another mechanism that can explain how human beings die. In many ways, Larcher says God is not the one who is authoring disease per se, but rather God will allow for us as human beings to fall sick, for us to experience illness and diseases, so that in that suffering, we are turning to God, we are repenting of our sins, we are engaging in spiritual practices, we are engaging in prayer, we are engaging in fasting, We are turning to our social support, our network, our community of elders to come and lay hands. We are looking to God for spiritual healing in addition to biological healing. And in that way, suffering can be redemptive and transformative because you are being convicted with what you might have done in the past, any wrongdoings, you're repenting of these things, and it helps to redirect our paths back to God. But Black theologians are very cautious about hearing about suffering in a way that it is good. Emily Towns, the former dean of Vanderbilt Divinity School, writes in her book, A Troubling in My Soul, suffering and any discussion that accepts suffering as good is susceptible to being shaped into a tool of oppression. It is here that we understand that when we are instilling in people that suffering is a good thing and that you must turn to God, but we are ignoring the fact that social suffering exists because of folks who, dare I say, those who have been Christian in the name of God, have been doing and instilling suffering on other people, then we are completely neglecting the fact that the evils that exist in this world that impose social suffering on those who are historically marginalized is unequal. And that suffering can be conflated with how we understand all types of suffering. Or better yet, in our context, for those who care about health and health disparities, for people who are sick and afflicted with certain conditions, certain diseases, we are enabling them to grapple with God in a way that can be problematic. We've seen this come up in other pandemics and epidemics, where we've seen this with the HIV/AIDS epidemic, where this was a way that Christian folks would sometimes say that this is God's punishment. We would see this in certain conversations, even around COVID-19. We would see this even in certain conversations when we're thinking about reproductive rights and reproductive health. There are ways that we sometimes will use suffering and weaponize suffering and our theological discourse of suffering to make it seem as if that you are in your suffering, you must turn to God and ask God, what did I do? Why me? Rather than also taking into account that our society socially imposes suffering on certain people, certain bodies, just because of who they are. And we don't do enough of that heavy lifting in our theology of illness more broadly to understand what is happening here, how can we overcome this, and also how can we help people who are suffering and say, some of this ain't you. Some of this is the fact that where we are, this is just a manifestation of, and we have to help you get out of that as well. And so it is a conviction, and it should be a conviction for many of us that we can pray. We can pray. God hears all prayers. As James, as the book of James would say, or as some of my church mothers would say, big prayer, big power, little prayer, little power, no prayer, no power. Right? We can pray and we should pray. And I would advise us as Christians to continue to pray. However, as Christians, we also have to be on the side of saying, this is not the world that we are supposed to live in. God is not pleased. The way that our society is shaped right now cannot continue on. We have got to do better. And I'll even say that I've been focusing on Black folks for the entirety of this presentation, in part for couple of reasons. One, because I'm Black, and so this is an intimate experience for me. And I think it's important to speak from my experiences when I'm talking about these types of topics. But also, this not just Black folks who are experiencing racism and medical racism, or the intersection of racism as it affects our health. When COVID-19 came to the United States, we immediately saw the anti-Asian hatred immediately come about and be and that was something that we tried to explain away through different reasons and rationale. We see different movements across the history, specifically the Young Lords, a Puerto Rican activism group that overtook Lincoln Hospital in New York because they were not receiving adequate health care. Racism is affecting a lot of us. And so in many ways, we have got to fix this. We can pray and we can continue to pray. We should pray. We ought to pray. It is our duty to pray. It is also our duty to do something beyond prayer. As I close, as I wrap up my presentation, I realize that I've been using this word a lot, and so I should have probably defined it earlier, but bear with me, folks. So racialization is a term that we use a lot in psychology. It describes the way that we as our society and as other societies will construct race as real. We construct race to also advantage some people, predominantly those who are white, and disadvantage others, particularly those who are Black, but again, those who are Latinx and also other racial and ethnic minorities. And we assign certain values based on racial identities. And so when I was thinking about this presentation, again, thinking about how is it that we think about and see God in the healthcare system, I just did a quick Google search out of boredom, out of curiosity, and I typed in two simple words, Jesus and doctor. It should alarm us on this call, the amount of pictures that we see from Google that say, and show us rather, that Jesus is white and Jesus sits alongside white doctors. Back in the day when I was a seminarian, Ellen Davis, professor of Old Testament, presented to us a picture of somebody and said that this might have been the person of Jesus Christ. Now, of course, no one knows what Jesus looks like. And thank God the body isn't here for us to dig back up. That in and of itself is a testimony, but it says something that in America, in our time, we are unable to divorce whiteness from Jesus. It says something harmful that we have racialized even our Jesus figure, whereby if I typed in Jesus, doctor, and Black, I would get one or two photos. But when I type in Jesus and doctor without any type of racial identity, all I am inundated with are these pictures of a white man and a white male Jesus standing alongside, working with white male physicians. This may not and should not feel an attack on those who are white and male, but it says something symbolically that we, knowing that Jesus was someone who was born of a woman of color, knowing that Jesus was someone who was a man of color because of where he was geographically located and the time in which that he was born, we know that this is not who Jesus looks like. Yet we are so married and attached to an image of Jesus that feels safe. But my question is, safe for who? Is it also possible that Black maternal mortality rates would not be where they are today because of medical neglect if we imagined and knew that the body of Jesus came from a woman of color? Because at that moment, then we would feel so committed to saving her life too. Because we know that Jesus, a man of color, was born from a woman of color. And so that she who birthed him must also be saved at all costs. Are we willing to reimagine who our Jesus is as a mere starting point of tackling a larger question of dismantling racism in our society and also in our healthcare system? Will we be committed to doing that? I want to thank everyone for the time today. I want to thank you for allowing me this space to offer these heavy topics and thoughts and musings of my mind. I recognize that this was not an easy conversation to have, and I also hope, though, that this was something to invite us to consider when we're really thinking about how we can change this healthcare system overall. We have got to do a better job. We've got to think about what equity looks like. And dare I say it, we start by reimagining who and what Jesus would look like in the hospital room. Thank you. Thank you.
Many, many thanks, Jason. Thank you. Thank you. We've got about 12 minutes for questions and conversation. I see Alejandra Salemi's got her hand up, and Alejandra, I invite you to unmute and turn on your video.
Yeah, thank you so much, Brett. Can you all hear me? I can't see myself, so that's okay.
Yes.
Also, Jason, thank you so much for your chat. Your conversation made me think so much about the ways that in public health and in medicine, we've shifted away from race as a determinant of poor health outcomes and racism actually being the issue here, and racism being a measure of poor health outcomes. And it makes me think about the way that we measure whatever topic we're talking about really helps us get to better science, better understanding of systems and the ways they work. And your differentiation between Black church and maybe more of a white church makes me think about the way that we measure religion. If we're trying to bring any type of association or understanding around religion and health outcomes, I would love to hear your thoughts on maybe gaps or opportunities that are being presented right now in the scholarship of religion and health, with how we kind of measure religiosity and religion, and how we can become better scientists in understanding what religion is measured by, so that we can create associations or causations to various health outcomes, and really just calling out the ways that religion can fight against racism, or it can also uphold it, and we don't have a good way of really measuring that.
Yeah, thank you so much for that question. That was a heavy question. I'll try my best to answer it as quickly as I can. This is something that I have been thinking about deeply now too. I think that a lot of the research that we are looking at looks at these kind of global measures of religiosity, where we're looking at how frequently people are attending religious services or church services, how frequently people are praying, how frequently people are meditating or reading scripture or using religious and spiritual coping. In a lot of ways, this also tends to center the Christian narrative, even though we're saying that this is supposed to be religion more broadly. That number one is not a great thing. I think that if we are saying that we're talking about religion, we need to be talking about religious diversity. Otherwise, we just continue to center the Christian, or we tend to normalize Christianity in this research. Additionally, like you said, and it's so poignant to bring this up, there was just a recent report released by the Pew Research Center where you will see the vast difference in terms of Black churches that are talking about racism in their spaces and churches that identify as predominantly white churches or even multiracial churches, and the vast difference in how salient racism is in those church spaces compared to others, right? And it also says that you hear less about sexism and less about other isms and phobias. It goes to show, though, that just attending religious services every week, you might be hearing completely different sermons and completely different biblical interpretations. And so there needs to be a push for our field to start delving into some of these differences and these nuances. Of course, I'm going to shout out my mentor, because she's here, Dr. Bentley Edwards, who's starting to even ask these questions about denominational differences within the Black church. We make this very kind of large generalization about Black folks being more religious, without even nuancing the fact that Black Presbyterians and Black Episcopalians and Black Pentecostals, Black Methodists, we all have different theological questions and inquiries and grapplings, and how we come to the table. And each week, if we're receiving that in different ways, then all of those can affect our health. It is not simply some of these easier global measures. I think what is most challenging, though, is that a lot of epidemiological studies tend to rely on these easier, and I say easier because, you have a lot of measures that people are filling out very quickly. And so that also limits a lot of our access to these deeper questions. But the problem is we have to be as committed to looking at religion as nuanced, if we're interested in health outcomes, just as much as we're interested in all the nuances of structural racism and neighborhood disadvantage or educational attainment, or how we're experiencing discrimination. Is it racial every day? Is it by gender? Is it by other manifestations of who we are? Is it online and vicarious, right? So we're developing, or we're moving a lot in those other domains of life, and I feel like religion is far behind. And so thank you for that great question, and I hope that you and I will continue having those conversations.
Thanks so much, Jason and Alejandra. See Aubrey's hand. Aubrey, if you wouldn't mind, turn on your screen and turn on your audio.
Yes, thanks so much, Reverend and soon to be Dr. Ashe, for your presentation. There were a whole bunch of books on your slide 19, which were related to the excessive celebration of suffering as being oppressive. Yes. And I wonder, as a white woman who would love to get started thinking and reading on this topic more deeply, where would you recommend starting?
Great question. I would absolutely read everything that Emily Towns has written. I would say that she has been the leading Black theologian and womanist thinker in this space. Now, that's also not to diminish Stephanie Mitchum as well. I think that there are Carla Holloway also, who I have on the screen here, a former Duke professor, I believe. I would start with their literature. And something that I received from Ebony Marshall Turman is, when you're done reading the book, read the list of citations and read those books. And I think that that actually has been something that is a good practice as well. I think that this, again, there are a lot of people who are talking about theological bioethics, attention to racism, and that deeper question about who is suffering more and how do we answer that. I think that is something that Black theologians, in particular womanist thinkers, are doing very well. So I would point to their work.
Thanks so much.
Yes, thank you.
Thanks so much, Aubrey. Thanks so much, Jason. I see several hands. I've got a question in the chat, so we'll try to move quickly. Dr. Nicole Larrier.
Hey, good afternoon, everyone. Thank you so much for being here. Back in one of your really early slides on social determinants of health, where you had up some stuff about PTSD, and I'd like to sort of just re-emphasize and get your thoughts a little bit. Maybe I'm having some guilt about, we have this clear epidemic of the slaughter of Black men at the hands of law enforcement. And a question that always comes up is, well, why did he run? Why did he run away? And this, just last night on WRAL, there's this big argument with one of the reporters. Well, nothing would have happened if he didn't run. And if you could just sort of speak a little more, because I find like by the time I'm at the third death in a week, I start thinking the same way as a Black woman. And then I start to feel guilty. And then, it just sort of keeps spiraling. And then I have to sort of come to something like this that remind myself, why did he run? He ran because of the history that he probably doesn't even necessarily know that has been passed on to him.
Yeah. I 100% agree. I think right now, one of the ways that we are experiencing a lot of vicarious racism as Black folks is the continuous media consumption of Black folks being killed by law enforcement, whether they be white and or otherwise. I think that what continues to happen is that there is a respectability politic that follows up every single time in terms of how to police Blackness, even when we're innocent. And so what is harmful and continues to be harmful is that there is never going to be an adequate response, except for teaching white police officers and teaching law enforcement, white and or otherwise, to stop treating us like we are second-class citizens, right? Like there's no other response beyond that. Every time we are going to why did he run, that is a way that we are assigning the blame to the victim of what has been a hateful act. I will also admit, I do that too. I thought that for the recent events. I thought that for Eric Garner. I also then watched Tamir Rice die, and I said he didn't even have a chance to run at the age of, I believe, 12 or 14. It goes to show, though, that the response for him was, well, why was he outside playing with a gun? You have white men outside who have real guns and they don't get shot. There are ways that they police Black folks in the media and in our culture that we are not able to escape. So it's not, I would invite you and myself, because I know I will have these days again in the future where I will go back to this like, gosh, I keep blaming us for us dying. And it's like, this is not our fault. We have to continue to figure out how to survive this foolishness until the rest of America can kind of catch up and realize that this is on them to also undo their hatred for Black folks, for Black men, for Black women, for those who are gender and sexual minorities. They continue to hate us and then continue to police our responses after these things happen. Tyree Nichols was running because he was scared. And the sad part is, I don't know if any of us would not be scared after Tamir, Sandra Bland, Rakia Boyd, Renisha McBride, Eric Garner, Philando Castile, Alton Sterling, Oscar Grant, Amadou Diallo. Again, why do I have to keep saying these names? I'm tired. Yes, thank you for that question. Thank you.
Thank you.
Thank you so much, both of you. We're right up at time. Meredith has a question about health inequities on incarcerated folks, and I'll invite Ashley Gilmore to turn on her mic if she wants to ask her question as well. Or if Ashley dropped off, that's fine. So Meredith, go ahead.
Sorry, hi. Hey, Jason, good to see you.
Brandon.
Hey, so my question is, in light of it being Black History Month, what tools can you offer white churches on how to have this conversation on a more consistent basis, and just not Black History Month, but on a consistent basis?
Yes. Ashley, that's a really hard question. I'm honestly unsure. Because at this point, I'm unsure why we're still here. Right. I'm unsure why George Floyd was a wake-up call for many people, when again, a lot of those names I said were before George Floyd. Right. So I don't know what it's going to take. I think there is a laziness that needs to be confronted in the Christian church at large, but I will push predominantly white churches to take up that laziness, because this has been going on for far too long. It came from white churches that we as Black folks don't even like to read the epistles right, because there's too much of slavery represented in there, and we're like, we can't read Paul the same. Right. I think that there is something that needs to be done. Duke does a good job in requiring a BCS course, but at the same time, I was at Duke and I heard microaggressions against me in the classroom. I don't know. I really don't know. And so I think that again, I lean on the wisdom of Dr. Ebony Marshall Turman sometimes. Sometimes this work ain't for me to figure out. I think that that's something that they got to figure out too.
Very valid point. Thank you.
But thank you for that. I'll think about it.
Thank you both. Yeah, and thank you especially, Jason, for just this talk and your overall work and witness. Deeply grateful for you. And in hopes that this talk will be helpful, we'll have a recording up pretty soon of it for that resource to be shared pretty widely. And in 2 weeks, we'll have our next Theology, Medicine, Culture seminar with Emma Green from the New Yorker, formerly with the Atlantic. Her talk is entitled, "Can We Live Together? The Crisis of Journalism in America?" And she's done quite a bit of work on public health questions. But one more time, please join me in thanking Jason, and peace to you all this afternoon.
Thank you all.